Yep, just
Great.
okay.
And then I can share.
I'm making you the host.
Okay.
There we go. So just as I've done that, a couple more people have joined. Can you please mute your microphones?
And what I'm going to do, just tell me if I've got the screens right. Can you see just a single slide, or are you seeing my presenter view?
I am seeing a single slide and next slide in small.
Yeah, okay. So I'll just swap. Now you should just
There we
see
go.
one slide.
Single
Okay.
slide, yep.
All right, thanks. Thanks everyone for coming. Okay, so yeah, I'm a professor of orthopaedic surgery at University of New South Wales and at University of Sydney. I work in Sydney as an orthopaedic surgeon, but also do a lot of research in orthopedics. And the topic of this talk is about surgery for musculoskeletal pain, which is really a lot of the surgery that many of you would be handling with clients. A lot of it is for musculoskeletal pain. So what's the evidence for doing this kind of surgery? So just as an overview, the most common reasons for surgery in the world are musculoskeletal. It's either injury or chronic musculoskeletal disorders and things like arthritis or degenerative conditions. So that's the most common reason for surgery around the world. And the most common and costly surgical procedures are also musculoskeletal in nature. So the top three costs to Medicare in Australia for surgical procedures in order are knee replacement, hip replacement, and spine fusion. And they're all done for the relief of musculoskeletal pain. So I think it's worthwhile having a look at this topic. So why do we operate? It's really two reasons in the orthopedic field why we operate. Overall, we want to improve quality of life, but we either want to relieve pain or improve function. And when we're going to be looking at these surgical procedures and how effective they are, we need to consider how we assess effectiveness. And this is quite an important question, because traditionally and still many surgeons assess the effectiveness of what they do based on what they see. And I actually had a discussion with some surgeons yesterday, and we were talking about the evidence for a certain procedure, saying how this procedure might not be needed as much as we thought. And one of the surgeons said, I can only go by what I see. And I responded by saying, no, you can go on the evidence of studies that you haven't seen, that, you know, on patients that you haven't seen. And yet surgeons just tend to rely on what they see in their practice. But unfortunately, what they see in their practice is terribly biased. And surgeons do believe what they see, but they tend to see what they believe. And I'll go into that in a little bit. What we should do if we want to assess the effectiveness of anything, whether it's a drug or a surgical procedure, is to test it scientifically. And the scientific method tells us that we should use the method with the least error. And so traditionally, these are randomized trials. Within randomized trials, there's good and bad as well. And preferably, we like to use blinded randomized trials where the patients don't know what they had. They're a lot better because they reduce bias even further. The whole idea of the scientific method is to reduce bias. So let's look at an example of where this occurs. And knee arthroscopy is probably the classic example because it's been used for, if everyone could go on mute, please. I'm getting some background noises from somebody.
Yep. Please all mute your microphone. If you don't know how to do it, slide the cursor down to the bottom of the screen and the thing that looks like a microphone, click on it.
They're still getting some background noises from Andrew.
Andrew Lingwood, Fran Smith, Karen Winters, Rahini. Got quite a few people who have not muted themselves. Please do so.
Knee arthroscopy is a good example. So it's been used for decades for degenerative knee conditions, and we always thought that it worked. Evidence told us that it didn't work, but surgeons didn't believe that evidence. Even within randomized trials, you can see how good trials can give you different results to bad trials. So the more scientifically and the more objectively we study things, and the less error involved in our study design, the closer we get to the truth. And we end up with studies like this. So there's two studies here. Both of these are RCTs. So both of these are randomized trials, but this one is a terrible study. I don't think the patients were randomized. All the patients knew what they got. Nobody was blinded. It showed a huge difference where those who had the arthroscopy had a massive benefit, like an 80% benefit compared to a 14% benefit in people in the control group. So this shows arthroscopy to be massively effective. But this is a terrible trial. In a trial where you actually blind people and you use a proper placebo, like this study here, you find no difference whatsoever after 1 year, 2 years. And if anything, well, no, there's really sort of no significant difference. So this is a low bias study. There is also a thing called clinician bias, and this is what I'm talking about. We tend to believe what we see, but we also tend to see what we already believe. So our preconceived notions taint what we see. So, for example, if you ask surgeons about total joint replacement, if you were sitting next to an orthopaedic surgeon at a dinner party and you said, how successful is total knee replacement? They would say it's very successful, it's 95% successful. And then next time you're sitting next to a physio, ask them how good knee replacements are, because they'll tell you they're terrible and the patients are in pain for ages and it takes forever to recover and it's not a great operation. And that's because they see things differently. And we need to get to the reality, and the reality is what the patients think. So we did some studies where we asked the patients how satisfied they were with the operation. Then we asked their surgeons how satisfied they were with the operation. And there was a significant discrepancy between the two. So surgeons tend to overestimate the benefits of surgery and underestimate the harms. We did the same thing for tibia fractures, where we found that 67% of surgeons were happy with the results of the tibia fractures that they treated. But when we interviewed those patients with the tibia fractures, we found only 44% were satisfied. So there's this huge discrepancy between what surgeons think and what is reality. And this has been shown in a systematic review published in the last few years in JAMA Internal Medicine, showing that consistently, looking at all studies where this has been examined, clinicians tend to overestimate the benefit and underestimate the harms of what they do. Now, the problem is that when you go to see a surgeon for a knee arthroscopy or a knee replacement or whatever procedure it is, they're going to base that recommendation on their own perception of the surgery, and their own perception of the surgery is wrong. It's an overestimate of how good it is, and it's an underestimate of the harms. So, and this is the problem. This is why we have too much surgery. And the resistance to the evidence is very interesting. So there's been now roughly a dozen studies comparing knee arthroscopy to non-operative treatments or placebo. All of them now, all of the proper randomized trials show no benefit to surgery. And there's now been more systematic reviews of those trials than there have trials in the first place. And we published a systematic review of all of the evidence for knee arthroscopy, and we concluded that not only is there no benefit, but further research is unlikely to change the outcome. In other words, we've got so many studies now we don't need to do any more. Here's another systematic review published in the same, around about the same time as ours. And this was published by surgeons who think that knee arthroscopy is very helpful. So they did a review of all the evidence. Now, what they found was the same thing that every other review found. They found no difference between arthroscopic meniscal debridement compared with non-operative management. So the conclusion of the review was that all of the evidence, when you put it together, this procedure doesn't work. Their conclusion, however, was that more research is urgently needed to support meniscal surgery. So what they're saying is all of the evidence so far tells us that this doesn't work. So we need to keep doing studies until we find one that shows that it does. And a lot of this is based on personal experience, where surgeons believe that they see patients get better, not understanding, of course, that patients would have gotten better anyway. And so it's this logical fallacy, and it's what drives a lot of hocus pocus medicine and old wives' tales and things like that. And everything my mum used to do to me to get me over a common cold used to work very well because I got over the common cold every single time she treated me with whatever it was she treated me with. And another example is that surgeons believe that what they do works, and they can pick the patients that get better. They can say, sure, now arthroscopy doesn't work on everybody, but I can pick the patients where it does. And so we did a study where we showed surgeons, sorry, just going to go back to where I was, where we showed surgeons some scenarios, and we said, do you think this patient would get better with knee arthroscopy or not? And they said, oh, this one definitely will, this one definitely won't. We found that their guesses were no better than chance. So surgeons can't pick who's going to get better because the procedure doesn't work. And the blowback against this kind of thing is even seen in editorials. This is an editorial written in Arthroscopy by the editor of the journal. When he was commenting on these placebo trials that showed arthroscopy to be ineffective, he said patients who may not be of entirely sound mind are selected, and research performed on such individuals would not be generalizable to mentally healthy patients, which is itself absolutely crazy. And the argument that, oh, it only helps with people with mechanical symptoms, that's been answered, where we looked at the researchers looked at the patients with mechanical symptoms and found, if anything, those who had the real arthroscopy actually did worse. And now there's evidence that those who get an arthroscopy are actually more likely to need a knee replacement, because doing the procedure and taking things out of the knee damages it. So not only is it not helpful, it's probably harmful.
You can share your screen again now, sir.
Sorry?
You'll need to share your screen again.
Oh, sorry.
Sorry.
How do I do that? Hang on. Yeah, we heard a few noises there.
Yeah, sorry about that. I had to quickly reclaim host and mute people because they weren't muting themselves. Okay. There we go.
All right. Okay. All right, so let's get back to it. So, but the rates are falling. So we can see that the evidence does get through, even though surgeons don't believe that it works. Eventually, the evidence gets through, and so you can see the rates are heading downhill. But we wanted to do this review, looking at what is the evidence for what we do, because in knee arthroscopy, clearly it's not very good, but we're still doing it. So we looked at surgery for chronic musculoskeletal pain. What is the evidence? And we looked at all of the common procedures that we do. So the aim of the study, and it's published just in the last year or two in Pain, if you want to look it up, the aim of the study was to look at surgical trials on common surgical procedures for musculoskeletal pain. And we just want to look at the randomized trials. Now, there's lots of randomized trials out there, of course. There's thousands of randomized trials on orthopedic procedures. But we wanted to look at how many of those randomized trials, the proportion of randomized trials that compared doing the procedure to not doing it. Because if you look at surgical trials of total knee replacement, for example, it's all about technical aspects of, should I do this suture or that suture, or this approach or that approach, or this prosthesis or that prosthesis. And it's very rare to get a study that says, should we do it or not do it? Same with knee arthroscopy. There's lots of studies showing you different techniques of doing a knee arthroscopy, but very few studies that compare doing it to not doing it. And we wanted to look at of those studies that compared doing the procedure to not doing it, what proportion were favourable to surgery? And we defined favourable as statistically significant and clinically important. And we just want to see how many of these trials are blinded, because we know that they're the least biased studies and more likely to be true. So we picked the 15 most common operations. There's a list of them there, but it's all the typical things: some shoulder surgery, carpal tunnel, disc replacement, spine fusion, hip and knee replacement, arthroscopies, things like that. So these are the common operations that most of you would see getting done on clients every day. And we excluded things, acute things and things for tumor, because they're not done for chronic pain. They're done for different reasons. They're either done for acute pain or to, you know, restore alignment or reconnect a tendon. So we're not looking at that. We're looking at pain. And so what we did is we searched all of the literature, the Cochrane, which has a list of all randomized trials ever done. And we looked for systematic reviews and randomized trials of these topics. And we had a really broad search strategy. So when we were looking at the topic of rotator cuff repair, we searched everything that had rotator cuff as a subject heading. So for example, from that, we found 314 randomized trials. And for all the other procedures, here's total shoulder replacement as another example. We just looked at anything to do with shoulder replacement, and we found 34 RCTs. So let's take that through and find out what proportion of those RCTs actually compared doing it to not doing it. So after removing duplicates, we ended up with 312. So there's been 312 randomized trials on the topic of rotator cuff repair. There's only been 4 that compared doing a rotator cuff repair to not doing a rotator cuff repair, and only one of those was favourable. Total shoulder replacement, we mentioned there's 34 RCTs on the topic of total shoulder replacement. There's never been one study that compared doing it to not doing it. And here with subacromial decompression, a very common shoulder procedure, 389 randomized trials, 15 of them compared doing it to not doing it. 14 of them showed that it was of no benefit. Only 1 showed that it was favourable. Interestingly, 9 of those studies were blinded, and so on and so forth. So we went through every procedure. I'll just pick out some popular ones or common ones. Surgical fusion for chronic pain in the neck. There's only been 2 RCTs comparing it to not doing it. None of them are favourable. There's been 9 RCTs comparing spine fusion to no fusion. Only 2 were favourable. Interestingly, 4 for a laminectomy in the lumbar spine, none of them were favourable. We've expanded on this evidence for spine fusion in another article we published recently, which you may want to look up, and it looks at spine fusion for all reasons, not just for chronic pain. But getting back to the current study, this is an interesting one, knee replacement. So knee replacement, we said that's the highest cost item in Australia. So something like about 2% of the health budget goes to knee replacement alone. So this is several $1 billion a year goes to knee replacement. There's been 2,356 randomized trials published on the topic of knee replacement. There's only been 1 that compared it to not doing it. And the arthroscopy we've already mentioned, thousands of RCTs, nearly a dozen comparing it to not doing it, none of which were favourable. Carpal tunnel decompression, this is interesting. There's been 8 studies comparing doing a carpal tunnel decompression to not doing it. Less than half of them were favourable. Yeah, that's still a very common operation. So the overview is that less than 1% we found of all the RCTs done on these topics compared doing the procedure to not doing it. And of those, only 15% were favourable to surgery. So 85% of them didn't show a clinically important benefit to doing the operation. And yet these are the most common operations done. That's how we chose them. Interestingly, 9% of all the studies were blinded, where the patients didn't know what they had done. And when you looked at the blinded studies, none of them were favourable to surgery. Now, what's the relevance to into the insurance sector and workers' comp and things like that. Well, many of the common procedures that we do under workers' comp and that we approve are for degenerative conditions and for chronic pain related to musculoskeletal conditions. They're joint replacements, arthroscopies, things like that. And these are done largely for chronic pain related to workplace injuries. And yet, from my personal experience, I would say that most of these are degenerative in nature, they're non-traumatic, and there is a pre-existing degenerative changes. Whether the patient admits to symptoms or not is another thing, and that would have caused symptoms anyway. And so it's not really related to the workplace injury, in my opinion, most of the time. But even when it is, we're doing operations that are probably not effective, like spine fusions and knee arthroscopies and shoulder arthroscopies. So in summary, I hope I've been on time, a little bit ahead of time. The evidence for surgical procedures for chronic musculoskeletal pain is lacking. And in fact, the evidence that we have largely points to these procedures not working. So the evidence we have that is available is not supportive. So I'll end the talk there and I'll stop sharing.
Wow. Very much like your previous talk, the evidence is irrefutable, isn't it? I mean, it's so clear. And yet, as you say, you know, we are seeing every day people wanting or people being referred for surgeries or having ongoing complications after having had an allegedly successful surgery. People, does anyone like to ask a question of Prof Harris? Now is your chance. You can unmute yourself and fire away, or you can type your question in the chat.
There is one in the chat. It says, please address the provision of cortisone into joints and those results. Yes, it's largely ineffective. And so particularly where it's mainly done is in the spine. And there's all sorts of, epidural, transforaminal, facet joint injections that are done in the spine. And the evidence from the least biased studies, so in other words, studies where there's a placebo and studies where patients don't know what they had done, show that these are no more effective than not doing it. So these are largely ineffective. If I wanted to argue for them, and I have argued with rheumatologists about this, they feel that there is probably some short-term benefit when injected into a joint, such as the knee. And they would say that, well, if a patient's going on a walking trip to Europe or something like that for a few weeks, if I give them an injection, it'll last them a few weeks. But it doesn't actually benefit them in the long term. It doesn't reverse the arthritis. And if they do have a knee replacement within 6 to 12 months of a steroid injection, they've got an increased risk of infection as well. So orthopedic surgeons tend not to do it. But it's done a lot in the spine, and there's not a whole lot of evidence for it. Mm-hmm. The next one is, if the research disproves the efficacy of surgery for these conditions, what mode of treatment would you recommend in most cases instead? It depends on the cause of the patient's problem. And largely, I see in the workers' compensation sector, patients who are dissatisfied and unhappy and expressing that as pain in the back or pain in the knee, and sometimes the journey that they have to go through in the workers' comp environment adds to their problems. And you have a patient who might have had a twist to their knee at work 2 years ago, but whatever injury that caused has long since gone. But since then, it's psychosocial factors that have taken over. You can fuse that patient's knee, you can inject that knee, you can arthroscope that knee, you can physio that knee, you can put steroids in that knee. It won't make any difference. The patient has a chronic pain problem, not a pathological process in the knee that can simply be removed and then suddenly they wake up from the anesthetic and they have no pain. So I don't see a lot of these, the patients I see anyway, maybe I see them at the end of the line, I don't see them as largely having simple mechanistic problems where they have a single problem in a level in their spine where there's a dark disc on the MRI and they just need to have that disc replaced, removed, fused, physioed, whatever, and then they'll be fine, because there's really no correlation between degenerative discs on MRIs and back pain. So most people my age and older without back pain have degenerative discs. It's just, there's just no association. So we need to get away from treating the physical problem. And how I would treat them, I would change the system that they're being treated under. So that's a bigger topic than we can cover here. But I would also treat them not just with physical things. So multidisciplinary chronic pain management, that kind of thing, getting them out of the adversarial environment. And sometimes there's nothing we can do. And there's this problem in healthcare in general, where we have to treat. And sometimes that's not in the patient's best interest. And surgeons do this. They say, well, you know, if you're not going to let me do an arthroscopy, I'll have to do a knee replacement, not realizing that they don't have to do anything. Sometimes doing nothing for the patient is actually the best thing, because they'll avoid the harms from the ineffective surgery. Biceps tenodesis or tenolysis. Yeah, that's a good question. There was a study done, a placebo study, but that was in the presence of slap lesions in the shoulder and actually showed no difference to doing a biceps tenodesis compared to placebo. But that was in that particular setting. In the presence of rotator cuff degenerative tears, I'm not sure if there's much evidence that it makes any difference. So I can't really comment on that, I'm sorry. Another question, personal question, turning 40, left lateral meniscectomy 2000, remaining meniscus removed in 2003, tricompartment OA seen on imaging. Likely prognosis. Okay, stem cells are a complete waste of time. There's very clear evidence that stem cells do absolutely nothing to osteoarthritis. They never would. Theoretically, there's no basis for it whatsoever for a degenerative condition. It just sounds good. And so people pay $11,000 to have stem cells injected into their knees. That's what currently happens. And in America, people fly to Mexico to have it done and stuff like that. It's a complete waste of time. There's good studies showing that it just doesn't work. Knee replacement I would only have if you couldn't do anything else. So if your knee is so bad that you can't enjoy life, you can't walk properly, maybe you're looking at a knee replacement. But a knee replacement does not give you a normal knee. So osteoarthritis is best treated, you know, depending on your size, of course, with weight loss and exercise, and they're the most effective treatments. In fact, there was a study done in Melbourne where it was just published this year in JAMA Network Open by Michelle Dowsey. And it's a great study. They actually randomized people who were on the waiting list for knee replacement. So they had really bad arthritis. They were due to have a knee replacement. And they randomized them to weight loss surgery versus no weight loss surgery. And they found that the people who had weight loss surgery obviously lost a little weight on average, not everyone, but on average they lost weight. They were looking at a difference in complications around the surgery. But what they actually found was that nearly 30% of the people who had the weight loss surgery didn't even need a knee replacement. So they didn't go ahead with the surgery because their knee got better. So one of the most effective treatments for osteoarthritis, if you're obese, is to lose weight. Maintaining good exercise works. I saw a patient yesterday who's got bad arthritis of the hip. I thought was heading for a hip replacement. We sent her for some physio. She came back 2 months later and said her pain's all better. She doesn't want to have any surgery. Now, will she need surgery? Sure, because she's only 50 and she's got another 50 years to go. So she's probably going to need surgery at some stage, but she doesn't need it now because there's other ways you can treat it. How do we break the cycle of inappropriate early imaging? and inappropriate early referral to orthos within a week or two, stop paying for it. I think that's the only way you can break the cycle of things, is you have to change the system that drives it. At the moment, we don't have that system. We have a system where it's very easy to get a referral to a specialist. It's very easy to get an MRI scan. And particularly for back pain, it's a disaster, because every patient aged over like 20 or 30 is going to have an abnormality on the MRI scan of their spine. I've been in practice for over 25 years. I can swear I have never seen the report of an MRI scan of the spine that says everything's fine. I've never seen one of those reports. So every single MRI scan of a spine that I have ever seen has something wrong with it. And so that makes the patient think that what they're seeing on the scan is causing their pain, which is usually not the case. But sometimes surgeons think that as well, and then they operate. Education is the other thing. I mean, educate the GPs, educate the patients as well, that they don't need to have this. So some form of public education is something else we're working on, but that's very difficult to do, because unless you create a viral video for free, you're paying millions of dollars for public education. It's very difficult to get money for that. It's easy to get money for surgery. It's hard to get money for public education, but I think that's probably what we need. Becomes very difficult to decline requested surgery. That's right. Many of us are not doctors. This becomes very challenging. Excellent. Okay, so this is like best question ever, because that's exactly right. You know, if the brain surgeon says that this patient needs their neck fused, from top to bottom, it's very difficult for the claims manager to say, I don't think so. And then you become the bad guy, and the patient saying, oh, they're refusing to give me my life-saving treatment, and it's complete disaster, and it's easier just to approve it. So what we need is some kind of screening process, because single surgeons on their own make bad decisions. Multidisciplinary teams make good decisions. So patients shouldn't be seen by a single surgeon. They should be sent for a second opinion, and it should be to a multidisciplinary team who can sort out this person's problem. It should be pain management people, physios, a dietitian if needed, a psychologist, a surgeon. Have that team look at the patient. I'm sure you'll come up with a different answer than surgery most of the time. In fact, they did a second opinion study in the insurance sector in Brazil for patients who had spine surgery recommended, and they sent them for a second opinion. And most of them, the second opinion disagreed with the first opinion. And in fact, in 11% of the patients, the second opinion felt that they didn't even have anything wrong with their spine at all, and yet spine surgery was recommended for them. So a second opinion with the multidisciplinary team is better. The other alternative is to have these requests go through a panel. They've done this in other jurisdictions where you have a panel of sensible surgeons and maybe other specialists, and they say, oh, this patient's got some degenerative discs. They want to fuse them from top to bottom. There's really no evidence for that. There's no neurological signs. We shouldn't approve this. And then it's refused by a panel of senior peers. And then for that average Joe surgeon out there in the community, he's now, or she has been told, that you can't have surgery by people that are senior to them. So that's a very different situation to the one you're faced with. And these are easy to implement and easy to trial. And if they don't work, we don't do them. But these are things that we can at least try to do.
The Northern Territory does something quite similar to that. They have a 3-panel where they have 2 of the same type of surgeon or specialist, and then a third person who is often an occupational physician, and they are deliberately chosen for their seniority. And as you say, it is providing a very valuable second opinion.
I believe they've done that in Queensland as well, and it's really changed the amount of spine surgery that's done there. It's so easy to do. I really think it should be done. There isn't a peer panel that you can access. I mean, there isn't any kind of panel formed. So I guess all you can do in the meantime is get a second opinion with a sensible surgeon, or a third opinion.
Yeah. Look, everyone, we're going to have to finish up now, but I want to thank you all for making your time available to listen to this. And thank you very, very much, Associate Professor Ian Harris, for your time today. The recording for this will be available in the next day or two, and you will all receive that. And hopefully you will join us for our other seminars as they come up. Thank you again so very much.
Thanks. Bye.